Intestinal and tissue cestodes and trematodes. So when we talk about intestinal helminths, helminths are worms. These include nematodes, which are the roundworms, cestodes, which are tapeworms, and trematodes, which are flukes. All inhabit a lumen space of the body, so parts that have direct communication to the exterior, such as the gastrointestinal tract or the genitourinary tract, lungs, those types of things. So the first worm we're going to talk about is Enterobius vermiculus. This is pinworm. Eggs are ingested. They actually hatch in the upper small intestine. The larvae then migrate to the iliacal region of the intestine and mature. The female migrates to the anus at night and lays eggs, and it becomes infected within 6 hours. This is the most prevalent helminth infection in the United States. It typically will be seen in children 5 to 10 years of age. We previously mentioned this when we talked about laboratory diagnostics, that this is a parasite that we can use the Scotch tape prep. So early in that morning, before the child has gone to the bathroom, the Scotch tape can be pressed against the skin areas around the anus, and then if there are Enterobius vermiculus eggs there, they will stick to the Scotch tape, and then we can look at that under the microscope on a slide and see if we see anything. So oftentimes the tube itself is good enough for the optics, so you don't have to actually transfer it to a slide, but you put it on your microscope stage at 10x. So this is typically an egg that has a translucent shell with one flattened side. Then we have Trichuris trichuria, which is known as the whipworm. The ingested eggs, they are ingested. They mature in the intestine, and they are like a barrel-shaped kind of looking type of egg. Trichuris infections with Ascaris, which we'll talk about, are very common. Again, children are the most common patient demographic. Your laboratory diagnostic is going to be based on visualization of eggs in the feces. These eggs will have bipolar plugs on each end. So it kind of looks like a football. So if you look at the picture, it looks like a football, and it's kind of got that weird clearing on the end of each side. That's kind of the plug that we were referring to. They are typically 50 to 54 micrometers long and 22 to 23 micrometers wide. Ascaris lambricornis, this is a large roundworm. Again, the eggs are ingested. The larvae will penetrate the intestinal wall and enter into the pulmonary circulation. Stage 4 larvae will actually migrate up to the pharynx, and then they are swallowed. So it's actually a re-entry into the gastrointestinal tract. So kind of gross to think about, but that's how they get there. Most prevalent in humans. Symptoms occur upon breakout of the pulmonary capillaries. So patients will have temperatures, asthma-like breathing, coughing, bronchial rales, pneumonia-like syndrome known as a Waffler syndrome. Diagnosis can be recovery of the fertilized or unfertilized eggs in the feces. Fertilized eggs will be about 60 to 45 micrometers with a thick bile-stained shell with small round projections called mammillations. And infertile eggs are going to be larger, so they're typically 90 to 40 micrometers. It's more of a distorted look and also has a mammillated coat, so you can kind of tell the difference if you look at the picture above. Ancylostoma duodenale, this is an old world hookworm, and the Necator americanus is considered the new world hookworm. So with the life cycle, these are similar. So the larvae will penetrate the skin from the soil, and the larvae are then carried to the right side of the heart and then into the lungs. From there, they migrate to the pharynx and again are swallowed, so we have that re-entry. And then it works its way down to the digestive tract to the small intestine. From there, it's attached by sharp mouth parts of the scolex. In North America, the Necator is the more common genus, and in Europe and the Mediterranean, the Ancylostoma is the more common. Now with hookworm, because they do have mouth parts that will attach to the small intestine, they can be a cause of chronic iron deficiency because of the blood loss within the intestines. Laboratory diagnosis will be finding an unimbranated egg in the feces, We are not able to differentiate hookworm eggs, so basically on the report you would just state hookworm eggs found. So Strongyloides stercoralis is known as a threadworm. Anytime you see the term autoinfection or auto-reinfection, you always need to correlate that with Strongyloides stercoralis. It is the only one that will do that. So Strongyloides has 3 life cycles. It has direct, indirect, or heterogenic, and the autoinfection. With the direct life cycle, the larvae penetrate the skin, move to the lungs, again are swallowed, then mature in the upper small intestine. The rabbitiform larvae are carried out in the feces. In the indirect, the rabbitiform larvae are passed in the feces. They develop into a free-living male and female, but free-living rabbitiform larvae transform into the infection flariform larvae. With the autoinfection, the rabbitiform larvae in the intestinal tract prematurely molt into filarial form and reinfect the host. For pathology with a cutaneous phase larva occurrence, it's a snake-like tract. Will usually be just right under the skin because the larvae penetrate the skin, oftentimes in the feet, because the larvae, again, will come from the soil. Pulmonary, there really is no obvious clinical manifestations for this. Laboratory diagnosis for strongyloides, 50% of the time is going to be in rabbitiform larvae found in the feces. If the patient has what we call a heavy worm burden, then there will be enough eggs that we can actually see it in the feces. They can also have a hyperinfection, so there will be filariform larvae found in sputum as well. The life cycle of the dwarf tapeworm begins with the ingestion of infective eggs. Once in the small intestine, the embryo is released from the egg and develops into a cysticercoid larva. This cysticercoid then migrates to the lumen of the small intestine where its scolex attaches to the intestinal wall, matures, and produces gravid progodids that release embryonic eggs. The dwarf tapeworm is the most common cestode infection worldwide due to its direct life cycle and ability to autoinfect. Most common mode of infection is hand to mouth, so passage of the eggs. Diagnostics for us are eggs found in the feces. On the outer shell surrounding a smaller inner membrane, which encloses a 6-hooked oncosphere. Notice that the 2 species are differentiated based on size. Tinea saginata and Tinea solium are beef and pork tapeworms, respectively. One way to remember this is matching the O with solium with the O in pork. And then we will talk about uterine branches here in a bit as well. So this is another way to remember. Over 13 uterine branches is saginata. So if you look at the words saginata and solium, saginata has more letters than solium, so it's kind of easy to remember that way. So uterine branches, if there are 13 or more, that's saginata. If it's less than 13, that's solium. So as the name indicates, the life cycle is ingestion of the larval stage called the cysticercosis, which is found in the muscle of the intermediate host. So if you eat undercooked infected beef or pork, that's how that tapeworm can enter into us. In the small intestine, the scolex will attach to the wall. Tinea saginata has 4 round suckers, where Tinea solium has 4 round suckers and 2 rows of hooks. And that's how both of them attach to the small intestine. Embryonated eggs in the gravid progodid are released either within the small intestine or after the progodids are passed in the feces, and they are immediately infective. The eggs are ingested by the intermediate host. The oncosphere is released in the small intestine, penetrates the intestinal wall, carried through the body, so the oncosphere can actually localize in muscle and transform into the cysticercosis stage. Tinea are endemic in Central and South America, Russia, Africa, and can be found in Latin American immigrants as well. Infection with the single adult worm typically causes mild clinical symptoms, mainly characterized by the passage of motile progodids in the stool. However, cysticercosis, which results from larval cysts developing in the tissues, is a much more serious condition and can lead to significant complications depending on the site of cyst formation. For laboratory diagnosis, this is primarily based on the detection of eggs or progodids passed in the feces. The eggs measure about 30 to 40 micrometers in diameter and are characterized by a thick, radially striated dark brown shell. Inside each egg is an oncosphere containing 6 distinctive hooklets, which is an important identifying feature under the microscope examination. We cannot differentiate species based on visualization of the egg. So if a tinea egg is found, you're just going to report that. You're going to report that you found a tinea egg. For tinea species to be differentiated, we need to see a gravid proglottid, and those will be stained, and then you're going to count the number of uterine branches that we mentioned earlier. So 7 to 13 is going to be tinea solium, which is the pork tapeworm. And then, 15 to 20, or greater than 13, really, uterine branches is going to be tinea saginata, which is your beef tapeworm. You can also do serology, and there can also be a biopsy as well. There's also a new species, just for your FYI, known as tinea asiatica, and that is from Asia. The Dibelophium latum, this is the broad fish tapeworm. It is acquired by eating raw or undercooked freshwater fish, so that kind of makes us the second intermediate host. We are infected with the second larval stage. The adult worm matures in the small intestine and attaches to the intestine by 2 suckers. Unembryonated eggs can be passed in the feces. If the eggs are in fresh water, they complete embryonation to the ciliated embryo, or what we call a coracidium. The coracidium hatches from the egg and is ingested by the first intermediate host, the predatory crustaceans called copepods. Inside the crustacean, the parasite develops into the first larval stage, the procercoid. When the infected crustacean is eaten by a freshwater fish, the parasite advances to the second larval stage, the pleocercoid. These are endemic in lake regions of colder climates and persist in areas such as Alaska and Canada. There is usually no pathological changes, but can cause vitamin B12 deficiency, leading to megaloblastic anemia. For lab diagnosis, the eggs will be detected in feces and identified by wet mount. The egg description, we will have unembryonated 60 to 70 micrometers long with an operculum at one end and a knob at the other. D. latum can be confused with P. westermanni. So P. westermanni is a lung fluke egg, and these eggs are found in the sputum. D. latum eggs are slightly shorter, with the widest point at halfway, with a knob opposite a less distinct, more rounded operculum. Definitive diagnosis by identifying proglottids, broader than long, with a central rosette-shaped uterus. Clonorchis sinensis is a Chinese liver fluke. We become infected by ingestion of raw fish that contain the larval stage called the metasarcaria. The metasarcaria exists in the duodenum, then migrates to the bile duct, and then matures to an adult. The embryonated eggs in the feces in fresh water with a snail as their first intermediate host. Fish are the second intermediate host, so after ingestion by the snail, the metacardia hatch, form the sarcaria, and then the sarcaria penetrate the fish and then transform into the infective metasarcaria, and then we ingest the raw fish, which is how we become infected. The definitive hosts for Clonorchis are dogs, cats, mink, and rats. As far as where they are found, it's in the Far East, so Japan, Korea, China, and Vietnam. They are rare in the United States, except for they can be found in immigrants. For pathology, the parasite causes inflammation of the bile duct lining, and chronic infection can lead to fibrosis, thickening, constriction, or obstruction of the bile duct. Laboratory diagnosis is eggs found in the feces. You may need to do a fecal concentration due to the small number of eggs that are usually found in the stool. This is a very small percolated egg with a very tiny comma-shaped knob at the opposite end. Size-wise, this is one of the smallest at 35 micrometers long and 19 micrometers wide. It also has on the operculum what is referred to as shoulders. Oftentimes, these are going to be diagnosed initially with a CT or an ultrasound. Paragonimus westermanni is another lung fluke. This is the most common human lung fluke that we will see. We become infected by ingestion of metasarcaria in the tissues of crab or crayfish. In the small intestine, the metasarcaria exist, then migrate through the wall into the peritoneal cavity. Then they migrate through the diaphragm into the pleural cavity and eventually find their way into the lungs. And then that's where they will actually mature as adults. Eggs are carried up the respiratory tract to the mouth. Perigonomus can be expirated or spit, so you may find it in sputum, or it's swallowed back into the intestinal tract, and then the eggs are passed through the feces. In freshwater, the larval stage penetrates a snail. The snail releases the cercaria, which invade the crayfish, penetrating the crayfish muscles directly or the crayfish ingesting infective snails. Inside the crayfish, the cercaria mature to metacercaria, which is the infective stage for humans. These are found in the Far East, in Africa, and in Central and South Americas. For pathology, it causes a chronic bronchitis due to lung infection and inflammation. So laboratory diagnosis is based on detection and identification of eggs in the feces or sputum. This one's a pretty good size at 90 micrometers by 55. Unembryonated and operculated, these are a definite area of thickening on the opposite end of the operculum. If it's in sputum, you can do a wet mount, or you may need to do a formalin ethyl acetate concentration procedure. They also have a serum diagnosis. So again, the serology testing is typically going to detect the antibodies that your body is producing to these. Fasciolopsis buski has two intermediate hosts, the first being a snail, and then the second being the aquatic plant. So we have an effective larval stage. The metacercaria is encysted on nuts or roots of the plants. If the plants are eaten raw, the metacercaria exist in the small intestine attached to the wall, and that's where they become adults. The operculated eggs are passed unembryonated in the feces and then reach the snail in the plants and then start that life cycle all over again. Unembryonated operculated eggs passed in feces of infected humans or pigs. In freshwater, eggs embryonate, forming a meracidium. The snail host is the first intermediate host, so the meracidium hatches and actively seeks a suitable freshwater snail. Inside the snail, it undergoes development, so it goes from sporocyst to redia to cercaria. Then it goes to the aquatic plant stage, which is the second intermediate host. So this is where the cercaria emerge from the snail and penetrate the aquatic plant. They insist on the surface, becoming metacercaria, which is the infective stage for humans. Then we have the human or pig infection, which were the definitive host. So the infection occurs by ingesting raw or undercooked aquatic plants with metacercaria. In the small intestine, metacercaria exist attached to the intestinal wall and mature into adult worms. For egg production and restart of the cycle, so adults lay operculated, unembryonated eggs that are passed in feces, which helps complete the cycle. For epidemiology and geographical distribution, these are found in the Far East and in Southeast Asia. The reservoir hosts are pigs. They are the major reservoir. Some risk factors, so consumption of raw aquatic plants or use of human or pig feces that they can use sometimes for fertilization. Laboratory diagnosis is detection and identification of the unembryonated eggs in the feces. The operculated egg is even larger than the Diphyllobrathrium latum, so it's even bigger. So we're at 120 to 180 micrometers by 60 to 100. Direct fecal exam may be confused with Fasciola hepatica. So we will use epidemiology to be able to differentiate that. So the patient, history, where they've been, stuff like that. So buski is more common, particularly in Asian countries with pigs. And Fasciola hepatica is rare in humans, but more prevalent in places that have sheep herding. The life cycle of Fasciola hepatica is nearly identical to Fasciolopsis buski. After ingestion of metacercaria from a contaminated aquatic plant, the larvae exist in the small intestine, then penetrate the intestinal wall, migrate through the peritoneal cavity, and invade the liver. They localize on the liver surface, then penetrate into the bile ducts where they mature into adult flukes. While common in sheep, goats, cattle, and horses, human infection is usually uncommon, occurring sporadically in regions like Cuba, France, and parts of Latin America. So we have two
Pathology
phases for
occurs in two
Bacillus
phases.
for
The
pathology.
first, which is the
The first
hepatic
phase,
phase,
the
involves
larva
larval migration
migrates
through
through
the
the liver,
causing
and then it's
necrosis,
associated with
fibrosis, and
necrosis
clinical
and
symptoms like
fibrosis of the
fever,
liver,
right upper
also
quadrant
fever,
pain,
abdominal pain,
diarrhea,
diarrhea,
and
and
marked
eosinophilia.
eosinophilia.
The
In the
second
second
phase,
phase,
after
once
migration
flukes
to the
reach the
bile
bile
duct, the
duct,
clinical
symptoms may subside
manifestations
or
will
disappear,
disappear.
though
So
chronic
it can be
biliary issues can
self-limiting
occur.
if there's not a heavy
Diagnosis
egg
is based on
burden
detecting
present.
large
So
operculated,
detection,
unembryonated eggs
identification
in the
of
feces.
the operculated
Serological
eggs or
tests
the
are
embryonated
useful,
eggs in
especially
the
during the
feces.
early migratory
And
phase
again,
when
there are
eggs may
also
not
serum
yet be present in
diagnosis
stool.
for this as well.